Good afternoon, everyone.
Sorry.
My name is Asha Usman. I work at the Mental Health Foundation Australia, and I'm your host for today's Lunch and Learn educational webinar. We begin by acknowledging the Wurundjeri Woi-wurrung people as the traditional custodians of the land on which our office stands, and pay our respects to their elders past and present. We extend that respect to any Aboriginal and Torres Strait Islander people tuning in today. On behalf of the Mental Health Foundation Australia, I would like to welcome and thank each one of you for attending today's Lunch and Learn education webinar on EEG signatures of childhood versus combat trauma, presented by Associate Professor Scott Clark. Before we begin, a disclaimer that this webinar is intended for educational purposes only and should not be relied on as a personal advice. Always seek the guidance of your doctor, psychologist, and other qualified health professionals regarding your physical and mental health. I would like to introduce our presenter, Associate Professor Scott Clark. Scott is a clinical academic and head of the Discipline of Psychiatry at the University of Adelaide. He is also a consultant psychiatrist in the Western Community Mental Health Service. Scott's research focuses on novel clinical trials and the use of biomarkers and biotype in the prediction of outcome in serious mental illness. He was awarded the Royal Australian and New Zealand College of Psychiatrists Early Career Psychiatrist Award in 2017 for his great work. He is also a lead investigator in defense-funded projects exploring the geomics of cognitive function and the use of novel aperiodic analysis of EEG in combat trauma. I would like to welcome Associate Professor Scott Clark for his presentation.
Thank you, Aisha, and thanks everyone for tuning in. So today we're going to talk about a novel analysis that we've been able to do on some very rich existing data. Some of the concepts might be a little bit complex, but I will try and step everyone through as we go. And I guess it represents a new frontier in terms of identifying people that might be at risk of PTSD using electroencephalography, using brainwave patterns. So post-traumatic stress disorder has prevalence of approximately 6 to 8% in the general population. And it occurs in sort of over a third of people that experience severe trauma, and particularly in combat veterans, refugees and victims of assault. There is some genetic heritability, so some people are predisposed to developing PTSD in the context of trauma. Not everyone gets PTSD in the context of trauma. It can be influenced by personal history, prior trauma, particularly childhood trauma, and other psychological factors that might mediate the regulation of fear and emotion. And PTSD has 4 major symptom categories: the re-experiencing of traumatic events, and that's the flashbacks that I guess people might be familiar with, the concept of PTSD avoidance. So people avoid triggers that remind them, that trigger these flashbacks or remind them of specific events. There's an alteration in arousal and activity. So people become hyper-aroused. It's very hard for them to relax, and they're really attuned into the environment around them, and can be very jumpy. And we'll look at startle reflex later on in the presentation, which is an example of an increased startle reflex is an example of increased reactivity to stimuli. They have difficulties thinking because they're ruminating about the events, and they're hyper-aroused all the time. And I guess we need to think broadly about the impact of combat and depressive and post-traumatic stress symptoms, the amount of psychological distress it causes, I guess comorbidity with alcohol and drug use, and also the tendency towards anger and impulsivity and suicidality. And we're currently looking at a larger database of this cohort from the TWERP study as part of the analysis of data informing the current Royal Commission. So the Middle Eastern operations prospective study is one of the largest studies of particularly Australian soldiers, but one of the largest studies in the world that looked at a range of detailed psychological and biological and physical health measures before and after deployments in Afghanistan. So there are subsamples within this cohort with combat exposure. They measured self-report symptoms, cognitive or thinking assessments, physiological measures like startle response and response to noise, baseline electroencephalography, so it's baseline brain waves, and blood-based markers, inflammatory markers and other markers. In this sample, increased pre-deployment trauma, so exposure to trauma before going out to combat or going to Afghanistan, was associated with greater risk of PTSD. Particularly interpersonal childhood trauma was associated with a higher risk, but also combat role, which predicted what sort of traumatic experiences the person had, and trauma during the deployment, pre-deployment symptoms, and post-deployment illness all had an impact on the rates of PTSD. And we can see here in these graphs that these separate lines, on the x-axis, we have a range of different scales for PTSD, depression, again for PTSD, and people with more trauma, more episodes of trauma at baseline were much more likely to reach criteria for PTSD or for depression than those that had less trauma. So the more traumas you'd have, the more likely it is that you would develop PTSD. And those with no prior combat trauma were actually more likely, less likely to develop PTSD. So the more exposure you have to trauma, the more likely you are to develop PTSD. So the sample was broken up into, can be broken up into different groups, some that had combat exposure, some that had childhood trauma exposure, and some that had none of either, and some that had both. On self-report, there was no association between prior combat deployment experiences and psychological symptoms. So people don't tend to report features of PTSD, even though they were more likely to have some symptoms of PTSD. And the quote was made in the overall report that it's possible that participants concerned about their ability to deploy, like their job security, didn't accurately report the symptoms. And so there is some need for a better objective measure of a person's exposure to trauma so that people can be supported appropriately in combat and while working in the military. And this Venn diagram here shows that there was significant rates of alcohol abuse that occurred outside of reported PTSD and reported trauma. Potentially this represents self-medication and unreported distress, and is another example of the underreporting of problems with trauma in soldiers. So this is a complex diagram, and I guess this is a section through the brain showing the inside of the cortex of one of the lobes. And we can see here that there are components at the front of the brain on the inside. There's the amygdala, which is inside the temporal lobe, and the hippocampus, which is involved in memory, and the amygdala is involved in fear responses. And I guess to take away from this diagram, the most important thing is that the frontal cortex is able to inhibit the amygdala and inhibit responses to trauma and stress. So the fear response, the frontal cortex can inhibit the fear response in the amygdala. And we can see here, these are brain images, and these are functional images of the brain showing activity and volume in different areas. And we can see that at point C with the red ring, that people exposed to trauma have smaller sized hippocampus, which is a part of the brain that's involved in memory. And they have lower blood flow in the anterior cingulate, which helps manage people's response to trauma. And they have a super sensitive pituitary response, hypothalamic response to stress. And so that cortisol, which is normally released under stressful conditions, is super suppressed in those people that have trauma. So there are biological changes and changes in the brain that are associated with the development of PTSD. So our study looks at electroencephalography, and so this is the measuring of brain waves, and we usually think about brain waves in different bandwidths. And so I guess one of the common bandwidths you might have heard of is the alpha wave, and that's associated with eyes closed, quiet wakefulness, limited activity. And then we have fast spiking inhibitory processes, gamma, and these things are associated with more activity. Beta is associated with more brain activity. In people with PTSD, there is asymmetry in the amount of alpha power, and it suggests that there's exaggerated physiological arousal that impairs the filtering of environmental distractors. So the brain circuitry is not able to as easily filter out noise in the environment. There's exaggerated responses to stimuli in the frontal central parts of the brain. And what that suggests in behavioural tests is that people have difficulty screening out task-relevant distractors. So again, they have trouble focusing in a noisy environment. There's also attenuated parietal responses, and overall, there are problems with attention dysregulation. So people have problems concentrating on daily tasks, and they're hyper-focused on anything that may be threatening. So traditionally, EEG looks at those bandwidths and looks at oscillating activity, activity that waxes and wanes. But underneath that activity is an aperiodic component, which is represented by this graph here. It's a function of 1/f. And the slope of that component, so this is the noise that sits under the oscillatory activity, tends to shift with illness and with aging. So with schizophrenia, there's a shift to a lower frequency, which means that there is an increase in the lower frequency and the waveform tips upward. As people age, there's a shift to higher frequencies, which means the right end of the graph tips upwards and there is more fast wave activity, a shift to high frequency. And this changes the nature of the underlying circuits and potentially brain function. The aperiodic component is somewhat complex to understand, and it can shift to understand more about the meaning of this underlying aperiodic component. It's thought to represent the fundamental balance between excitation and inhibition in neural circuits. So in the cortex, there are generally large pyramidal neurons and these small inhibitory parvalbumin positive interneurons that control and regulate normal function. If we take the example of schizophrenia, there is less of these interneurons, and that results in increased signaling and increased noise and abnormal function of the circuit compared to balance feedback inhibition. There's less inhibition of the inhibition, and so the circuits are noisy and the brain doesn't function as normal. And what that does is because there's a reduction in fast spiking waveforms, fast oscillations, the whole curve is shifted upwards, suggesting that there's greater power at lower frequencies because the faster frequencies have reduced. Interestingly, we can see a trend in ECT where with repeated treatments, there is also an increase in the aperiodic waveform, suggesting that lower frequencies increase. So we can see this EEG, there is a level of noise that is associated with the tuning of the circuit, whether the circuit is faster responding or slower responding, or suppressed or excited. And we can now mathematically remove that from standard EEG. And what we tried to do in that study is to see if that underlying noise, if the excitation inhibition balance actually changed in people with different types of childhood trauma, suggesting there were different changes in the brain. And so we took the MEOP sample and we looked at PCL scores. So the PCL is the PTSD checklist, the civilian version, and it has a number of symptoms of PTSD. We can see at the scale that people can rate in terms of their significance in their experience. So repeated disturbing memories, repeated disturbing dreams, sudden acting or feeling if a stressful appearance were going to happen again. So reliving an experience, feeling upset, having physical reactions, so heart pounding, getting startled easily, avoiding thinking about things. So there's the avoiding component again, avoiding activities, trouble remembering, so impaired memory, impaired cognition, loss of interest, changes in sort of interest and mood, feeling distant, feeling as the future somehow cut short, trouble with sleep. So all of these are features of diagnostic features of PTSD. And so we can see that in this sample, so we were able to get baseline EEG before people. So these people had differing amounts of previous trauma, but at baseline before they went out, were deployed into combat, we were able to, the study measured those features. And so this is a study, this data is originally collected by Sandy McFarlane and the Centre for Trauma Studies at University of Adelaide. And I guess the participants were young. They had a reasonable amount of combat exposure on average. They had relatively low levels of PCL at baseline. So some people had, only a handful of people had symptoms to the level of PTSD at baseline. And these scores for re-experiencing avoidance and arousal as part of that scale are all below threshold. So only 5.3% actually met the criteria for PTSD. So what we also had was a range of trauma exposures. So a questionnaire was asked about people's prior experience with trauma exposures. And what we did, rather than use standard measures, standard clusters, which tend to cluster trauma into interpersonal trauma versus sort of combat trauma, we actually wanted to get a good measure of how well different types of trauma were distributed within this sample. And we used a technique called exploratory factor analysis. And what we're able to do is cluster different types of trauma and develop a score along these three clusters for individuals and people that these clusters included a complex or developmental trauma type cluster, which had high weighting for domestic violence and child abuse, a non-complex or compact trauma, which had high weightings for combat and life-threatening accident, witnessing a killing, so combat features, and then a mixed trauma group, which had some physical child abuse, but also had some other exposures. But this group was fundamentally different in the way it clustered. And these you compare these to the standard clustering of trauma, and we feel that we have a more representative clusters, which would be easy to use for our EEG study. So using these clusters, we actually had a well stratified sample. So we had 104 that were combat naive, 31 that were trauma naive altogether, 74 that were both trauma and combat naive, and 31 that were combat naive as well. So we had a good range of subgroups. And we used it, we had data on 26 channel EEG. So this is a map of where the EEG electrodes are in the brain. And each of those electrodes, it records a waveform, and that data is available to be able to process. We used those categorical trauma groups, and we also looked at adult versus childhood trauma. And we looked at the number of traumas in some complex modelling to attempt to see if we saw brain patterns change with the number of traumas that people experienced. So what we found that developmental, but not mixed or combat trauma, was positively associated with PCL scores. So this is consistent with the other results. So people that had childhood trauma were more likely to report PCL, trauma symptoms. But we didn't find any association with PCL and the number of traumas or the timing of the trauma. And we didn't find any relationship of the PCL with EEG measures. And here, as we said previously, it potentially reflects some bias in reporting. So people aren't reporting trauma, particularly if the number of traumas and the type of trauma is not directly related. What we found in terms of the underlying slope was that it was negatively associated with developmental trauma. So as the trauma increases, the slope decreases, suggesting that the brain, the cortex was becoming more excited. And EC and EO are eyes open and eyes closed. So we look at EEG in those two states, because when people have their eyes open, it changes the waveforms. And we found, though, in the reverse, that the slope was positively associated with combat trauma. And so that suggests that the cortex was more inhibitory. So what we found there is a pattern that suggests that people that have a history of developmental trauma are less able to suppress their responses to trauma, as opposed to people that have had a history of combat trauma, where they're more likely to be suppressing cortical activity. So it says a difference and a pattern there. And there was an interaction between combat trauma, the number of traumas, and also the site of the trauma. The site of the measure. So across the surface of the cortex, the relationship between trauma and brain changes was different. And what we ended up with some complex patterns like this, and you can see there that there is a signature that was associated with non-complex or combat trauma that was the exact opposite of complex or developmental trauma. While we need to replicate these results in other samples, it suggests that there may be a signature that identifies combat trauma that occurred later in a person's development, as opposed to early trauma that occurred during childhood. We can also see here that the pattern varied with the number of traumas, and with more traumas, there was a move towards excitation. So the results suggest that with complex trauma, and we know with trauma in general, there's prefrontal volume loss, so the volume of the brain's lost, and this is mainly those inhibitory interneurons that I showed earlier, which are sensitive to cortisol. And those inhibitory interneurons are very fast firing, fast spiking, and they're much more sensitive to insults. And so the resultant increase in cortical excitation may lead to dysregulation of hypersensitive amygdala circuits that are triggered by the trauma itself. But we also see that hippocampal volume is reduced. So the flatter exponent in the developmental trauma group indicates cortical excitation, and the trauma related to the decrease in the frontal volume suggests there's lots of inhibitory neurons, and there's also a change in the maturation in that group of normal balance in the circuit, EI balance. It may be associated with increased cortical glutamate, increased excitation that we can see in children following developmental trauma. And I guess what it represents is an abnormal, is an insult, a change in the normal development of cortical limbic circuits that regulate emotion and regulate stress. And I guess there are also protective proteins that cluster around in a net around developing circuits. And trauma can also influence these perineural nets and cause abnormal fear responses to become fixed. The circuitry is less plastic, and so that again predisposes people potentially to developing sort of further trauma and PTSD down the track. So if we compare that to non-complex combat trauma, which has a steeper slope, suggesting that the cortex is in a more suppressive state, it's a more inhibitory state. And there are suggestions that stress in a normally developed cortex changes EI balance in specific ways. And I guess promoting a more top-down suppressing state. So people that develop, I guess, resilience factors tend to when exposed to combat trauma, tend to be top-down suppressing, have less cortical reactivity. Okay, so very different patterns. I'll just move on now to talk about the startle reflex. So the startle reflex is I guess, is the normal jump that someone might have when they hear a loud noise, but this is exaggerated in people with PTSD or with responses to trauma. It's usually measured with an eye blink reflex, and so they use electromyography. You can see the electrodes there to measure the eye blink response to noise, and you can see the waveform, the resultant waveform there. And in anxiety disorders, you can see that the fear startle response is potentiated to the startle stimulus. So the circuitry underlying this startle response is actually quite complex, but the grey area down the bottom shows the brain regions that this operates through. But there are inputs from the cerebellum and the cortex that regulate other responses. So the response is actually quite complex, but there are a number of brain regions involved. So another way to measure the startle reflex that is more that is more reliable is prepulse inhibition. And so prepulse inhibition uses a prepulse, a stimulus before a second stimulus, to see if that produces lesser response, a lower response. And in people that have increased PPI, this prepulse doesn't suppress the normal response, the normal eye blink response. This is a much more reliable measure than just measuring the straight startle response. And so interesting, what we found here is that there was no significant association between, again, the trauma scores and startle amplitude or latency. So there was a number of different measures that we used. We did find a significant positive association between self-reported PCL and probability. So this is over time, the likelihood of an increased startle, which suggests that those with more PTSD had an increased startle response. There was a negative association between non-complex trauma and startle amplitude, which was interesting. I guess, again, there, potentially that's inhibition from top-down inhibition, because we know from the previous EEG study that potentially these people are top-down inhibiting. But we got the same response with people with complex trauma, and I guess mixed responses across the rest of the data set. So in conclusion, we found that trauma clusters are clustered into developmental and combat-related and mixed groups. And reported PTSD symptoms were associated with more prominent developmental trauma rather than past combat trauma. So the periodic slope varied across the scalp by trauma cluster and the frequency and timing of the trauma. And it may be that developmental trauma may alter after normal, may alter the normal neurodevelopment of these brain circuits. We found a complex response with the startle, and it appears mostly inhibitory. So trauma itself is mostly inhibitory on the startle response. And we need replication, but there are some promising signs for further development of this as a biomarker. And I guess people with markers of developmental trauma may be at a higher risk of developing PTSD symptoms.